Thanks for listening to Hand Surgery Resources podcast on giant cell tumor of tendon sheath. This podcast highlights the typical presentation of a giant cell tumor of tendon sheath, including the scientific background, symptoms, signs, diagnostic workup, goals of treatment, treatment options, and potential complications associated with this lesion. In 1852, Chassaignac first described the fibrous xanthoma. Since his initial publication, many names have been used for this tumor, including tenosynovial giant cell tumor, xanthoma, giant cell tumor of tendon sheath, xanthogranuloma, benign synovioma, fibrous xanthoma of synovium, sclerosing hemangioma, and pigmented villonodular tenosynovitis, or PUNS. Currently, the World Health Organization classifies these lesions into two groups. Group 1 is called localized tenosynovial giant cell tumors, or LTGCT, and accounts for the vast majority of the hand and wrist giant cell tumors. The rarer Group 2 is called diffuse tenosynovial giant cell tumors, or DTGCT. The localized giant cell tumor of tendon sheath is the second most common tumor of the hand after ganglion cysts. The differential diagnostic list for a potential giant cell tumor of tendon sheath includes ganglion cyst, mucoid cyst, lipoma, foreign body granuloma, fibroma, synovial hemangioma, tophaceous gout, schwannoma, rheumatoid nodule, and infantile fibromatosis. Giant cell tumors are rare lesions with a reported incidence of 10 cases per million. The typical presentation is a female patient between 40 and 50 years of age, with rare cases in the very young or in elderly patients. The most common complaint is a slowly enlarging mass, lump, or localized swelling. While this lesion can be reportedly present for a few weeks, a case was reported where the lesion was present for 30 years at presentation. On average, patients report the lesion was present for a year and a half before they saw their surgeon. The vast majority of patients present with an enlarging mass. Less than 15% of patients complain of pain, which is usually mild. On exam, tenderness is observed less than 5% of the time. Further, some pain may be secondary to coexisting digital arthritis. It should be noted that the typical case has a slight predilection for the dominant hand, with a notable propensity for the mass to occur in the radial digits, especially the thumb, index, and long fingers. Some patients associate a traumatic event with their enlarging mass, but in most cases the injury brought attention to a mass rather than causing the mass. Typically, this lesion enlarges very slowly. It never gets smaller like a ganglion cyst, which can rupture spontaneously or secondary to trauma. When examining the hand with a giant cell tumor of tendon sheath, the first step is to localize, visualize, and palpate the mass. In the fingers, it often presents dorsal to the DIP joint, where it should be distinguished from a mucoid cyst, or volar to the PIP joint. These lesions are rare in the palm of the hand. The mass is usually firm and smooth, with occasional bumpiness if it is multilobulated. The majority are non-tender, with size averaging 2 cm by 1 cm. The adjacent soft tissues should be carefully palpated for any signs of associated satellite tumors. The range of motion of the involved digit should be recorded and compared to the motion in the same digit in the uninvolved hand. When a giant cell tumor of tendon sheath is adjacent to a joint or invading a joint, it may interfere with active range of motion. This range of motion defect may also impede grip and pinch. Transillumination of the giant cell tumor of tendon sheath is usually negative. These lesions do not transilluminate like ganglions or create a ring flash like lipomas. The digit with a potential giant cell tumor of tendon sheath should be examined for intact sensation. The course of the digital nerves should also be percussed to check for a positive Tinel sign. Approximately 10% of giant cell tumors of tendon sheath compress or attenuate the digital neurovascular bundle, which may cause decreased digital sensation or a positive Tinel sign. As with all masses in the hand, the lymph nodes should be checked for enlargement at the elbow and axilla. After a thorough history and a detailed hand and upper extremity exam, additional diagnostic workup such as X-ray, ultrasound, and/or MRI should be considered. Approximately 2/3 of routine X-rays will demonstrate positive findings such as soft tissue swelling, bone erosions, lytic changes in bone, scalloping of the bones, pressure defects in bone with possible cortical indentations, or rarely tiny bony burr holes. These findings will help define the invasive nature of the lesions and the involvement of adjacent bone and joints. Ultrasound is used less than X-ray or MRI, but it can be helpful. The echogenicity of the localized tenosynovial giant cell tumor can help define the lesion's solid homogeneous characteristics and differentiate this lesion from a ganglion cyst. Ultrasound can also verify the localized tenosynovial giant cell tumor's proximity to bone, vascular structures, and the extensor or flexor tendon sheaths. Further, ultrasound can verify the size of the lesion and identify satellite lesions. Currently, MRI is the state-of-the-art imaging modality for localized tenosynovial giant cell tumors. MRI allows the most accurate definition of the lesion and the lesion's relationship to adjacent joint, bone, and soft tissue structures. MRI optimizes the calculation of size and allows identification of bone involvement, joint involvement, satellite lesions, finger-like tumor extensions from the tumor, and tendon sheath involvement. Therefore, MRI imaging can be helpful for surgical planning. MRI shows decreased small-low signals on T1 and T2 weighted imaging due to hemosiderin, which causes a weighted spin echo sequence deposits. History, examination, and imaging studies allow accurate preoperative diagnosis in approximately 90% of the cases. Needle biopsies or fine needle aspirate can further increase preoperative diagnostic accuracy but are not frequently used. Aspiration can also be used to help make the distinction between a mucoid cyst or ganglion cyst and a giant cell tumor of tendon sheath. When aspiration obtains a clear mucinous viscous material and the lesion deflates in size, then this procedure is essentially diagnostic of a mucoid cyst if located dorsal to a DIP joint or a ganglion cyst if located in other locations in the digit, palm, or wrist. The treatment options are different for localized and diffuse tenosynovial giant cell tumors. In this podcast, the primary focus is on the treatment of localized tumors. There is no effective non-surgical treatment for this tumor. Therefore, the primary treatment for localized tenosynovial giant cell tumor is a complete open surgical excision. However, a true end block excision is not always practical for these aggressive but benign tumors. A marginal excision is often required in order to preserve function. While good surgical treatment demands complete tumor excision, maintaining good hand function may require saving a neurovascular bundle even if the localized tenosynovial giant cell tumor must be dissected off the bundle. Preservation of digital nerves and arteries may require opening the pseudo-tumor's capsule and using microsurgical techniques to dissect the tumor directly off the digital nerve and artery. This may result in some microscopic residual tumor adhering to the nerve or artery. At the current time, the best prevention of recurrence is meticulous attention to surgical planning and technique. These lesions are not isolated subcutaneous lipomas that can be surgically excised in a few minutes with minimal risk of recurrence or other complications. The localized tenosynovial giant cell tumor requires a tedious microsurgical dissection. To achieve this, the tenosynovial giant cell tumor excision should be done with tourniquet control of bleeding, appropriate anesthesia, and magnification to facilitate the dissection. Both the patient and the surgeon should be aware that this excision is a complex procedure. As soon as the tumor is partially exposed, the color of the lesion versus the color of the surrounding normal fatty tissues is visible. This subtle color difference between the lesion and the normal subcutaneous fat is critical to identifying tiny residual satellite lesions once the bulk of the tenosynovial giant cell tumor has been removed. The surgeon must be prepared to open involved joints with partial excision of the joint capsule or collateral ligaments. Depending on the joint involvement, collateral ligament reconstruction may be required. Moreover, in some recurrent tumors, joint fusion may be required. Whether this reduces recurrence because the joint and its synovium are eliminated or because the wide exposure of joint for fusion facilitates complete removal of the tumor is unknown. Similarly, the flexor sheath may have to be opened while still retaining the critical A2 and A4 pulleys. Small curettes may also be required for removing tumor from involved bony surfaces. The surgeon should also be aware that on rare occasions the tenosynovial giant cell tumor can invade the skin. An area that is especially susceptible to this is the skin on the dorsum of the DIP joint. In order to reduce the risk of recurrence, excision of involved skin and skin grafting may be necessary. Once the localized tenosynovial giant cell tumor is removed, a meticulous detailed secondary survey of the tumor bed should be performed with loop magnification. Remember the subtle color difference between the lesion and the normal fat. Any suspicious fatty-looking tissue should be excised. Without a doubt, the most troublesome problem associated with surgical excision of localized tenosynovial giant cell tumors is recurrence of the tumor. The reported incidence of recurrence varies widely. Average rates of recurrence as low as 4% and as high as 56% have been reported. Lanzinger's review of 17 review studies reported an average recurrence rate of 28.5%. Recurrence rates also increase after surgical care of recurrent cases. Recurrence also varies with follow-up of localized tenosynovial giant cell tumor cases, and follow-up also varies considerably. Follow-ups as low as 5 months and as high as 177 months with an average of 51 months have been reported. Meanwhile, other authors have shown an average recurrence rate of 1.5% at 1 year and 10.4% at 2 years. Recurrence is known to be greater in diffuse tenosynovial giant cell tumors than in localized tumors. However, recurrence has not been associated with metastatic lesions from giant cell tumors. Additional findings that have been related to recurrence of localized tenosynovial giant cell tumors include 1. Multicentric lesions seen on MRI. These satellite lesions have been reported as high as 17%. 2. Lack of a pseudocapsule. 3. Joint involvement, especially DIP joint. 4. Tendon sheath involvement and tumor invasion of the synovial fluid. 5. Bone invasion. 6. Involvement of the neurovascular bundles. 7. Tumor size, volume, and nodularity. 8. Anesthesia and experience of the surgeon and certain genes such as the NM23 gene. Clearly, post-surgical recurrence remains an unsolved problem. Further, it is obvious that complete surgical excision is the best way to prevent tumor recurrence. However, experience has clearly shown that this goal is not always achievable despite magnification, meticulous surgical technique, and awareness of all the risk factors related to recurrence. I hope you have enjoyed our podcast on giant cell tumors of the tendon sheath from the hand surgery resource team at the International Federation of Societies for Surgery of the Hand.